Good morning or good afternoon, wherever you may be. My name is Larry Gostin, and I'll be moderating this session. This is a conference session for COVID-19 in the Americas, and it's entitled "A People COVID-19 Vaccine, Ensuring Equity of Access in the Americas." And we have a really incredible panel for you. I'm very proud that I'm able to moderate this, and particularly because of the importance of equity, which is really at the heart of public health and global health. As I said, I'm Larry Gostin. I'm a professor of global health law at Georgetown University in Washington, D.C., and I also direct the World Health Organization, PAHO, Collaborating Center on National and Global Health Law. I'm very proud to have the director of PAHO here with us in our panel. We're going to have two panelists, and then the director of PAHO is going to be going through a question and answer period. But let me first frame this issue, this problem for us, because we're just over a year out since the first cases of the novel coronavirus were reported from Wuhan in China, where there was a zoonotic leap that within weeks and months literally gripped the world, and no one has gone unscathed. And the truth is that humanity has been no match for this virus, and that's particularly true in the Americas. And we've all suffered greatly, with the United States of America being, among the very worst performers. But there are also deep pockets of illness and deaths throughout the Americas, including Latin America and the Caribbean. So we now have a vaccine. In the United States, there have been two messenger RNA vaccines that have been given emergency authorization from the FDA, one from Moderna and one from Pfizer-BioNTech. There are additional vaccines that have just reported out this week, but have not yet been approved, but we think that they will be, from Johnson & Johnson and Novavax. There are also vaccines from around the world: AstraZeneca, Oxford, from the UK. There are Chinese vaccines. There's a Russian Sputnik vaccine. And so it's now a race against time, because we have widely circulating variants, and the virus appears to be quickly mutating. As a result, we want to get vaccines to everybody as quickly as we can. But because we have scarcity, there's going to be great problems of equity. We need to deal with equity within nations. For example, making sure that priority goes to the most disadvantaged, most marginalized populations, including racial and ethnic and other minority populations that have historically been underserved, as well as rural communities. But high-income countries, particularly the United States, Canada, the UK, the European Union, have bought up through pre-purchase agreements the huge swath of available vaccines, in many cases enough to vaccinate their populations 2 to 3 times over. And this leaves a huge equity gap, an unconscionable gap, because every human life has equal worth. And it's entirely unfair that your access to a life-saving vaccine would be attributed to where you live, to how much money do you have, what your nationality is. Vaccine nationalism has been a curse. When we should all be in this together, countries have splintered apart, looking at each other, looking at their own populations first. But beyond ethics, there's a huge reason for equity. As Dr. Tedros, the Director General of WHO, has said, no one's safe until everyone's safe. And with widely circulating variants, the longer we leave the world unpopulated, the more these variants are likely to mutate, to be resistant to vaccines, to spread more quickly, to become more pathogenic. And that's why equity is both a moral imperative, but also a global health and security imperative for all of us. We're all in this together. We have an incredible panel today, and we're going to start out with Abby Maxman. Abby joined Oxfam America as president and CEO in 2017. She's got more than 30 years of experience in international humanitarian relief and development, and she has a strategic focus on policies and systems to alleviate global poverty, and has particular experience in gender and power and social change. Prior to joining Oxfam, Amy served as Deputy Secretary General of CARE International in Geneva. She's witnessed the impact of poverty, injustice, war, and disaster firsthand. And she often says that she believes that the fight against global poverty and inequity is more important now than ever. And she's absolutely right. So, Abby, why don't I turn it over to you, and then I'll introduce our next speaker.
Thank you so much, Professor Gostin. It is such a pleasure to be with you all. I want to say thanks to Jonathan Hess and the University of Miami for the invitation, and it's a privilege to be here with Dr. Etienne and César Nuñez for this interesting discussion today. And as you say, timely, it is the moral and global health imperative of our time. And Professor Gostin, being one of the key signatories to our public letter calling for a COVID-19 people's vaccine, which I'll be speaking about more in my presentation. I'll also provide a brief background around Oxfam's work, discuss the intersections of COVID and inequality, and specifically look at the social, economic, racial, and gender intersections, and touch more deeply on the People's Vaccine Alliance and the policies that we believe can reverse our current trajectory. So for those who don't know Oxfam, we are a global non-governmental organization dedicated to ending poverty, inequality, and injustice throughout the world. We're active in more than 70 countries, working with local partners on a wide range of issues, including workers' rights, climate change, gender and racial justice, indigenous rights, hunger, and underlying it all, changing the unequal systems that are perpetuating poverty. We provide humanitarian relief, we engage in collaborative and innovative programming, and we conduct advocacy with public and private sector policymakers all over the world. Oxfam has worked for many years to draw attention, as Professor Gostin was talking about, equity. We've been focusing on this huge issue, the underlying groundwater issue of inequality, as a major driver of poverty worldwide, and one of the root causes of many of the different kinds of injustice we see on a daily basis. Now, we also know, and we've all seen, that the COVID-19 pandemic has lifted the veil on just how unequal our world really is. The virus has laid bare economic, gender, racial, and geographic inequalities, many of which intersect in important ways. The COVID-19 has killed more than 400,000 people just in the US. We know those numbers are rising, and infected over 24 million people. And each day, we're all watching the data. More than 4,000 Americans in the US alone died from the virus. And so to start my presentation, I want to talk a little bit more about one of those people. And I'll be introducing you to a man named Jean-Baptiste, a 44-year-old poultry plant worker in the United States and a father of 3 children. The US poultry industry has long put profits before the health and welfare of its workers, the majority of whom are migrants. A failure to implement proper protective measures in meat processing plants meant they rapidly became hotspots, as many of you surely heard, for the COVID-19 transmission and fatalities. When Jean-Baptiste contracted COVID-19, he was told to continue working and hide his fever. When he finally went to the doctor, his temperature was nearly 105 degrees Fahrenheit, and he was sent home. 3 days later, and sadly, these are familiar stories, he could not breathe. In hospital, he went into a coma, was put on a ventilator, and died alone. Now, the company did not contact his widow or inform his coworkers. After his widow told her story to the media, the company sent her a card and $100 in cash. Today, she is struggling to support her children alone. So the emerging COVID-19 vaccines represent a critical way out of this global health and economic nightmare, but only, and as Professor Gostin said, if everyone everywhere has access to it, which is why we need a people's vaccine that is free, fair, and fully accessible. Right now, there are 4 major challenges, however, to widespread access to the COVID-19 vaccines. Affordability, price beyond reach to many people and governments around the world, and essentially no affordability conditions on the vaccine developers, which rely on billions of taxpayer dollars. Vaccine nationalism, led by the Trump administration, has led to a small handful of rich countries with only 13% of the world's population cornering more than half of the global vaccine supply. Now, we can understand the temptation of public officials to protect their own constituents first, but it provides a false sense of security. It's a false choice. The virus will mutate and bounce around. We're already seeing evidence of this. And vaccinating all people in just a few rich countries will not only cost countless lives of people facing the daily onslaught of the virus, it will also exacerbate the health and economic risks Americans face. The third obstacle, vaccine production is still just way too low to meet global demand. Despite receiving massive amounts of US taxpayer dollars, more than $12 billion, and making record profits during the pandemic, the private vaccine producers exercise monopoly control over vaccine technology, which artificially constrains the supply. And the fourth obstacle, inadequate and unequal investment in public health infrastructure. Recent weeks have laid bare the challenges faced by the US and countries around the world to distribute the limited supplies of vaccines to their citizens, with doses languishing in pharmacy shelves in some places, even as people are dying. Now, this reflects decades of underinvestment and the underlying inequality in public health infrastructure that has the most pernicious effects on communities of color and those living in poverty in the US and around the world. The COVID-19 pandemic is also gendered, as is the vaccine. The COVID-19 vaccine development and delivery needs to be attentive to the social and political dynamics in which the vaccine is delivered. Women's work and their security are really at the heart of this. Across every sphere, from health to the economy, security to social protection, the impacts of COVID-19 are exacerbated for women and girls simply by virtue of their sex. The pandemic has decimated care systems from schools to daycare, prompting women to leave the workforce in unprecedented numbers and to take on new burdens at home. And in September alone, 4 times as many women as men dropped out of the labor force. Women in marginalized ethnic and racial groups are more likely to work in low-paid jobs in sectors such as retail or tourism that have suffered huge job losses during the pandemic and are less likely to have savings, redundancy pay, unemployment benefits to fall back on. And we see that unequal vaccine access only sets to deepen these growing gender inequalities. There are racial justice intersections as well. Black and Indigenous Americans and communities of color are getting sick and dying at vastly disproportionate rates. And many of these groups have suffered for decades, if not longer, at the hands of racist public health systems that, at worst, have actively threatened their health and well-being. And it is not surprising that these groups are more hesitant than the rest of the population to access a vaccine. So that's another barrier. Nearly 22,000 Black and Hispanic people in the United States would still be alive if they experienced the same COVID-19 mortality rates as their white counterparts. And we know these barriers can be overcome. And I'll take one example in Michigan, who made a concerted effort to prioritize testing, information sharing, and public health access to Black residents in the state, who are now recording lower levels of morbidity than the rest of the state. And then a last piece about an intersectional issue on the economic front. The COVID-19 pandemic has increased unemployment and dramatically slashed workers' incomes. Too many corporations are putting profits before worker safety, as the story of Jean-Baptiste noted, push costs down the supply chain, and use their political influence to shape policy to their own advantage. And our research shows that the world's 10 richest men, seven of whom are American, have seen their combined wealth increase by $500 billion since the pandemic began, which is more than enough to pay for a COVID-19 vaccine for all and to ensure that no one is pushed further into poverty by the pandemic. And so, as we hear from Jean-Baptiste's story, while largely white male billionaires ride out the pandemic in luxury, people in low-paying jobs and women in marginalized racial and ethnic groups are bearing the brunt of the COVID-19 crisis. They are more likely to be pushed into poverty, more likely to grow hungry, more likely to contract the virus, and more likely to die from it. So in response to this unprecedented crisis and the gender, racial, and economic inequalities that underpin it, Oxfam has helped to create the People's Vaccine Alliance to ensure that approved COVID-19 vaccines are available for all people everywhere equitably. This alliance includes well-known health, human rights, and development organizations from around the world, and more than 100 former and current heads of state, economists, public health experts, faith leaders, and artists, including Professor Gostin. And to achieve a people's vaccine, we are calling on public officials and industry leaders to collaborate to make all approved vaccines to be free of charge to the public in all countries. As you said, no one should be denied protection because of how much money is in their pockets, fairly distributed within and between countries based on need and risk, not wealth and nationality. Those of us working from a distance in rich countries not facing much risk should not be stepping in front of the frontline health workers or other essential workers facing these risks, be they in the US or around the world. And distribution plans should be guided by input from women's rights organizations so that the plans are taking into account women's unpaid care responsibilities. And they need to be openly licensed, free of monopolies, and free of proprietary protections, which are preventing the necessary rapid scale-up of production needed to meet global demand this year. We are urging governments and the vaccine developers to collaborate so that the technology and know-how to produce these vaccines is available for all certified producers anywhere in the world. Now, Oxfam is taking a number of steps to bring about a people's vaccine, using all of the influencing tools at our disposal with two principal targets: public policy and vaccine production. So we're influencing policy, the public policy targeting the executive and legislative branches of government. We're asking, we see that President Biden has a momentous opportunity to heal many wounds of this COVID era. And on top of this list is to do everything in the president's power, working with Congress to ensure this people's vaccine. We have met with President Biden's team and will continue to reach out to him to make important steps to safeguard the health of Americans and to restore US leadership around the world. And at the legislative level, we continue to champion legislation to enhance transparency, accountability, and speed and volume of safe production of COVID-19 vaccines. And at the vaccine producer level, we are having direct company engagement. We've met on several occasions with senior representatives for virtually all the major vaccine manufacturers, Moderna, Pfizer, J&J, AstraZeneca, and Merck. Investor alliances, we're working closely with the investors in these companies to help reach our aims for this people's vaccine. And as Oxfam, we have filed a shareholder resolutions at Johnson & Johnson, Pfizer, and Merck on COVID vaccine access, and we will support these asks in their annual shareholder meetings in the spring. So now is the time for a transformational reset so we can change this trajectory for people and families like those of Jean-Baptiste. Inequality is not destiny. We can overcome past injustice and use this moment to build a better and more equal future by delivering on a promise of a people's vaccine that is free and accessible for all and not just a privileged few. We can all be involved, and here are a few things that you can do, and I look forward to discussing as well further in this panel. Thanks so much.
Thanks very much, Abby. That was really brilliant and so important. Your service to the world is just phenomenal, and I can't say how much Oxfam means to the world. So thank you for everything that you do, and the people's vaccine is at the very forefront. Our next speaker is Dr. César Nuñez. He joined UNAIDS in 2007, and currently he's the director of UNAIDS's Latin American and Caribbean Regional Support Team. He spent 30 years in public service, and he's been working to improve health and welfare of vulnerable communities, beginning in his own native Honduras, where he managed the National AIDS Program at the Ministry of Health. He's a senior member of the United Nations Sustainable Development Group for Latin America, and he's been in support of the Sustainable Development Goals and implementation of the 2030 Agenda in the Americas. He's served the world, particularly in HIV/AIDS, for such a long time, and it's a great privilege to have you here, Dr. Nuñez, and I'll turn it over to you with appreciation.
Can you hear me?
We can, thank you.
All right, let me just set up my own slideshow here, and I hope you can see my slides now.
We can.
Thank you, Professor Gostin, and it's also for me a pleasure to be here in this panel chairing with Abby Maxman, with Carissa, Etienne, and of course yourself. As Abby and yourself mentioned, the issue of inequalities has been riding in the pandemic in the region of Latin America and the Caribbean. And I'm so glad that Dr. Etienne is with us today, because PAHO had been working with countries for many years in terms of preparedness. And from day one, they provided support to countries in the Americas. First, of course, in terms of the availability of PPE, then on diagnostics tests that would make sure countries identified where the pandemic was going, and now with vaccine access. But why again this inequality issue? Look at the Americas, with only 8.4% of the population in the world. Our share of the pandemic is much more than that. In terms of cases, we have reported 18% of the cases. And in terms of deaths, we have reported 27% of the deaths. So amongst the most affected countries, Mexico and Peru are leading the observer case fatality ratio per 100 confirmed cases. And we hear, or probably the audience has heard in the news about the limited number of beds available, given the surge that has taken over Latin America. In terms of death per 100,000 people, the world's top 10 include Peru, Mexico, Colombia, Argentina, and Brazil. So again, a disproportionate impact for countries in Latin America. And certainly in the first 2 weeks of January, we continue seeing that Latin America and Caribbean reports about half of the cases in the world. Oops. In terms of socioeconomical impact, we also have a disproportionate impact. We had a drop of 7.7% in the GDP compared to 4.3 around the world. And unemployment, a very critical number, 10.7 compared to 9.4. The foreign direct investment in 2020 fell by 8%. And these are significant numbers when you come to look at what this used to mean and the contribution to the fiscal space in the countries in Latin America. One aspect that was alluded to already is the disproportionate impact in women. And here, gender violence has been an issue that has been reported throughout the Americas as well. The World Bank had forecasted a rise in people living in extreme poverty from 3.3 to 4.3 million. And this in a region that was feeling proud of having gotten so many out of poverty in the past 10 years. The ILO is talking about an unemployment rate for the region about 10.7%. And these numbers will continue rising as we see this struggle between the economy and the health, and countries trying to make a decision on how to deal with them. In the case of the work with of UNAIDS, we work with key populations, with those being left behind, sexual diversity, LGBTQI, and they have been disproportionately affected too by the crisis. The crisis has magnified their existing vulnerabilities. Lockdowns and containment measures to mitigate the pandemic have hit particularly hard low-paid and informal workers. In some Latin American countries, the informal sector represents up to 70%. 7 out of 10 individuals need to go out every day and find the food that they're going to eat that day. That evidently does not bode well with the prevention about staying at home, or wearing a mask, or even washing their hands. In addition to this already complex scenario as a result of COVID, the region has also been facing unprecedented humanitarian crisis due to the situation of Venezuelan migrants, refugees, and asylum seekers. Colombia has so far exceeded about 1.5 million migrants and refugees. Peru is also above 1 million of them. And certainly these confinement measures, again, and social distancing, as well as mobility restriction, are generating increased risks in violence. Let me see. Oh, there. So the people's vaccine, I believe Abby has described quite well what the people's vaccine stands for. And certainly effective vaccines have become a game changer, but they will be a game changer if and only if there is a fair and equitable allocation, even with limited supplies. We have seen, and we're going to see in a bit, how many people have been vaccinated so far in the region. But the issue is that we're not seeing an equitable allocation, even with those small supplies. And the region has a very good experience in terms of immunizations. PAHO support in the immunization area through the revolving fund for the past 40 years has been a very, very good experience. And we hope that that will represent a good basis for what's coming in terms of the availability of vaccines. So since the creation of the People's Vaccine Alliance, UNAIDS has been a full member of the coalition of organizations as listed by Abby before me. And certainly the issues that are raised by the coalition, by the alliance, have to do with a vaccine that is being made available at true cost and free of charge to people. So far, evidently, the vaccines are being made free of charge to people, but we are looking at how the cost is telling or separating countries apart. Prevention of monopolies on vaccine production, that is a huge challenge at the moment. And we watch the news every day, and there is something new. We were watching the European Union discussions over the weekend, and limitations that have been placed on the exporting of vaccines outside their zone. Certainly that does not bode well with the fact that we're proposing a fair allocation of those vaccines. We need to see a full participation of governments. We also need to see civil society engaged in this decision making. When I make reference to the 2030 agenda and how it reads that civil society or the communities should be part of those sitting around the table when decisions are being made about development, it bodes so well with the process of decisions in the response to the pandemic, and particularly on social protection measures. We have not seen that, and we have seen many people being left behind. Again, on the populations that UNAIDS works the most during the pandemic, during the core of last year's confinements, we were able to see sex workers being forgotten. Transgender women being jailed because they went out of quarantine on the wrong day, particularly in the countries that had a gender quarantine, and so on and so forth. At the time of food distribution, these were populations that were not in the minds of people. What's going to happen at the time when vaccine distribution comes up? Are they going to be left out too? We hope not. We have seen the engagement of Latin American countries in contributing to global solutions. Costa Rica, for instance, supported the 15 region and supported by 15 region countries, promoted the COVID-19 technology access pool. And this was proposed last March 2020. President Carlos Alvarado himself and the director of WHO, Dr. Tedros, that's when this was launched. And this global initiative ensures the latest and best science available on COVID for the benefits of all humanity, and made universally available as a global public good. Again, this was backed by 15 countries in this region. In addition, a group of 11 Latin American countries co-sponsor, support, and welcome a proposal at WTO to waive traditional protections on intellectual property, allowing poor countries to make affordable versions of the vaccine. We haven't seen much progress on that. And also, I think it's important for me to mention how Colombia, Mexico, and Panama committed to fund the ACT Accelerator, another initiative. Here I quote the words of the Secretary General of the United Nations, Mr. Antonio Guterres, when he says, "We're all in this together and we will get through this together." It's so important that these do not become just elements of a narrative, but that we make them really anchors of the work that we do. COVAX, of course, is one of the three pillars of the Access to COVID-19 Tools Act Accelerator, which was launched again by the World Health Organization, the European Commission, and France in response to this pandemic, bringing together governments, global health organizations, manufacturers, scientists, private sector, civil society, and philanthropy, with the aim of providing innovative and equitable access to COVID-19 diagnostics and treatments. It was curious that on a recent tweet by Mr. Assi, former Director General or Secretary General of the Red Cross International, saying, "Why do we create mechanisms and then we do not support them?" Because it's what appears to be happening. I mean, we need a very strong COVAX, and I'm happy to have heard that President Biden is committed to putting resources into COVAX and hopefully making sure that vaccines will be made available to those who have less resources to purchase them directly. In terms of Latin America and the Caribbean, it is my understanding that the vaccines from COVAX will begin arriving in Latin American countries in March. It is expected that they will cover up to 20% of the population of each country. Let me stop here just for a couple of minutes, or a minute. The estimates, the mathematical modeling has shown or demonstrated that we need 70% of the population of a country vaccinated or immunized if we are going to be able to control the dissemination of COVID. And so it's a good start with 20%, but that's not going to be enough. All Latin American and Caribbean countries participate of the COVAX mechanism, with the exception of Venezuela, which is an issue that will need to be addressed. And because again, if anybody is left out, then there's going to be a foci for continued transmission. And it is at this the way that it's been set up right now. 27 countries will pay themselves for the vaccine. 10 countries will receive the vaccine at no cost. But I highlight here that a third of the countries so far rely entirely on COVAX. So we need a very, very strong COVAX mechanism for the Americas. As I already mentioned, concerns have been raised over the fact that several COVAX signatories are directly negotiating their own deals with pharmaceutical companies. And I'm gonna show some numbers in the next few slides. And obviously that takes doses off the market in a context where demand outstrips the supply. Our executive director, Winnie Byanyima, recently in an editorial in The Guardian wrote that we are witness to a vaccine apartheid that is costing us the quickest and least harmful route out of this crisis. And that is wrong. That is completely wrong, that we're seeing this develop around the world. It collides with the reality that production is both limited and controlled by profit-minded companies. And then also the agreements for production. We were so pleased to see how Argentina and Mexico had signed an agreement of production of close to 250 million doses. But that so far, we haven't seen move forward. Maybe we can hear more in the rest before we finish this meeting. Again, inequality among the many challenges, as it has been pointed out, the People's Vaccine Alliance has laid out very clearly, 9 out of 10 people in poor countries are set to miss out on the vaccine next year. Wealthier nations have bought up enough doses to vaccinate their entire population. And I believe that Canada is one of the countries that has an incredible excess of doses already with them. And 14% of the world's population have purchased up to half of all the most promising vaccines so far. This slide just to reaffirm what I just said in terms of the doses per citizen in rich countries versus poor countries. And again, the control of the provision of the vaccines, at least until now, remains apparently under the control of large pharmaceuticals. The current game rules not meeting the needs of low and middle income countries. And as of December 2020, none of the vaccine manufacturers had committed to sharing openly their intellectual property or joining the WHO CTAP. This graph proposes to show, this from The Economist, that it is possible to see that if everything remains as it is for the case of developed countries, the projection places this milestone by mid-2020. You know, they would have completed their vaccination. But for less developed, we're talking about January 2024. We are seeing new numbers every day. We are aware of the push for a scale-up of production of vaccines, and I hope that these graph of comparison can be improved before this year's end. This is the cumulative administered COVID-19 vaccine doses per 100 people. In the United States, it's close to 9%, Canada 2.5%, and here you have the Latin American countries. Costa Rica, even though they have received their first batches, they're still at close to 1%. Brazil, similarly close to 1%, and so on and so forth, until you get down to all the way to Ecuador. Look at this comparison. Latin American countries on the right, and other countries of the world on the left. Israel, everybody knows, has done perhaps the best job at scaling up vaccination. More than half of their population has been vaccinated already. But in the case of Latin America, all countries, it's less than 1%. So we need to definitely do a better job there. Even within the regions, you can tell the inequities. Chile, an OECS member country, Guatemala, a lower GDP per capita, and the stock to date in Guatemala is none. In Chile, they record at least about 4 million dosages already available from the 4 different sources. So it is definitely based on how much money you have, and the vaccine nationalism that we heard already about is there. What happened in the countries in Latin America and maybe in other parts of the world as well is that we tend to, when we do not see a solution, we do not find answers, then we start reverting to options that are out there, medications that may not be good to take because they haven't been tested or proved, but this is what people resort to. And there's a couple of them that have been debunked. There's a couple of them more that are still being studied. But look at this map on what the expectation is in terms of availability or widespread vaccination coverage achieved by the region. Those in red, we're talking early 2023, and we're talking the Bolivias, the Venezuelans, and in Central America, particularly the northern triangle of Guatemala, El Salvador, and Honduras, where we see many people migrating towards the north. Again, closing the gaps we'll have to deal with national vaccines regulatory approval, the logistics. I mean, at least the Pfizer, which was the one that was first approved by COVAX, not many countries in Latin America will be able to manage the cold chains or have trained personnel for mass inoculations. Other vaccines, I understand, will be approved by the end of February, and those are the ones that will do better in most Latin American countries. Financial capability or debt capacity. We already have countries in Latin America that are stretched so thin in terms of their fiscal space that getting into debt will be critical. I know for a fact that PAHO has been also assisting in conversations with international financial institutions in order to make sure that resources are made available for countries to procure the vaccines. An additional challenge that I mentioned before, there's currently more than 4.6 million refugees and migrants from Venezuela in 17 countries. And in their plans, in their national vaccination plans, 2 of those countries have expressly included the refugees and migrants, regardless of legal status. 5 countries have mentioned limited coverage to holders of regular legal status. And the rest do not include the provisions or do not talk about and mention them. Mr. Vitorino, the director of IOM, has mentioned that countries have to provide vaccination of all those who are present in their territory. And I know that I may be running beyond my time, Professor Gostin, so I'll run to my final reflections. production delays put even the pessimist figures in doubt. This needs to be addressed. Certainly, inequalities in Latin America bear a significant weight. Latin America is the most unequal region of the world, where 80% of poor people in Latin America live in middle-income countries. I already mentioned the informal economy of up to 70% in some countries, and fair and equitable access as a key to control transmission. I think an important point I wouldn't want to go without mentioning is that COVAX should be a permanent mechanism. There's bound to be more pandemics. Are we going to be prepared for the next one? Is COVID teaching us an important lesson on preparedness, and certainly how funding must be made available? Because the cost of vaccine inequality will not only be confined to those living in the poorest countries. We're talking about a global economy impact of up to 1.2 trillion in a year in GDP that cannot be recovered. And certainly, the longer the virus is allowed to continue in a context of patchy immunity, the more chances of mutations, as it has been described. I know that genetic surveillance is being done in LAC. We have at least one mutation has been reported from Brazil. There may be more. And as it has been said before, we are only safe if we are all safe. Thank you so much.
Thank you very much, César. The depth of your knowledge on the inequities in Latin America is stunning, and I did want to really strongly support your last idea of a permanent COVAX facility that is strongly supported regionally and also globally. We're because of the shortage of time, we've taken the choice to not go through question and answer, but ask our last speaker to sum up. Dr. Carissa Etienne is just, I'm so privileged to be here with you, Carissa. I don't know if you remember, we were together in the cafeteria of WHO in Geneva when you were first appointed as director of PAHO, and it was just so important for our region and the world. You're now going through your second term as the director of the Pan American Health Organization, and we're so delighted with your leadership. Dr. Etienne has her medical degree from the University of West Indies in Jamaica. She began her career in her native Dominica as Chief Medical Officer of Princess Margaret Hospital, later appointment Chief Medical Officer of the country. She's had numerous posts in Dominica, including Director of Primary Healthcare Services. She served as the Assistant Director General of Pan American Sanitary Bureau, PAHO, and 5 technical areas. Her research is on health surveillance and disease management. And she's, throughout her tenure and her long, deep service to the world at WHO and PAHO, she's really been a true inspiration on primary healthcare and strengthening health systems, and has been an incredible aspirational figure for reducing health inequities around the world. So, Dr. Etienne, it's a privilege, and I'll turn it over to you for summing up and ending our session. Thank you.
Thank you so much, Professor Gostin, for this introduction. But let me thank the 2 presenters. I think your presentations were riveting, they were challenging, and they captured the reality of the situation surrounding access to vaccines, surrounding the inability of many of our countries to have equitable access to vaccines. It captured very well the inequity that exists, not just in Latin America, but also in the United States of America, the Americas. And César, the Americas is known as the most inequitable region in the world. And we saw how this inequity played out in the really phenomenally high numbers of infections in the region, particularly among indigenous, our low-income families, families in poverty, and particularly also women, because women make up the majority of workers in the informal sector. And you touched very well on the fact that the developed countries, the high-income countries, to be safe, they require and they need that poorer countries have access to vaccines. And what we are seeing now, you also clearly laid out the fact that developed countries were having so much in excess of vaccines. They had already cornered the market long before the market existed. And so COVAX faces difficulty in ensuring that it does have the access to vaccines, which many 190 countries have signed up in the COVAX facility. I think it's important that we underscore as well that the pandemic has many effects, not only on the health population, but also on the economic and social aspects. And I think that was demonstrated very well in the populations. I want to refer to a document that we did with ECLAC, looking at the economics and the pandemic and the social factors. And we clearly made the point that until countries dealt with controlling the pandemic, until we were able to stop significantly the transmission, then we would not be able to recover the economy. Neither would we be able to move the economy forward if we did not take action on reducing the social inequities and ensuring that people had access to many of the social determinants of health. So it is not only enough to have safe and effective vaccines, and these have been developed in record times, but we have to get them to the entire population in an equitable and timely manner. So therefore I liked Abby's definition of what is a people's vaccine. And indeed, this is what we want. It's a people's vaccine. And we need, and the alliance needs to draw on a much wider swath of civil society organizations and governmental organizations as well to make that case and to define a real way forward, because it is the market forces are also driving the inequity, because countries who themselves had signed up to COVAX are now also engaging in the bilateral arrangements. It diminishes the ability of COVAX to access vaccines at a reasonable price to give to low-income countries. You know that some 92 of those countries also are what we call AMC countries, that COVAX will have to, through Gavi, provide vaccines for them. So I think that the region of Latin America and the Caribbean, supported by PAHO, I believe that we have the know-how to run immunization campaigns. There's more than 20 years of experience. I believe that they have the political will to do so. Countries have had to invest significant amounts of money to purchase vaccine through COVAX, and now some of them are doing it by bilateral arrangements. 21 countries in our region did have the storage facilities for even the Pfizer vaccine. So I think they have what it takes. We are continuing with training the healthcare workers on building the national vaccine plans and training and building capacity in health workers. but it is the access to the vaccine that is at the crux of the issue, that if we do not have access to vaccines, all of the plans and all of the training will not result in a timely control and eventually stopping the transmission. And I think we need to reiterate that the risk for the high-income countries is high if all of us do not have access to vaccines. So I believe that it is extremely important that we continue the fight for the people's vaccine. I like that. I love this. I think it is also time that we see a paradigm shift in our countries, particularly the countries of Latin America, but not just Latin America. We need to see a new development paradigm where we address frontally the inequity, where we ensure that people do have access to a health system that works and a health system that delivers quality services. I think it is time that we develop the capacity for our countries to themselves develop technology. Latin America has significant, in terms of economic and able countries, that we should be developing our own technology, including vaccines. So I think it's a time that we will have to bring significant change going forward. If our economies must recover, we must take on and ensure that people are at the very center of development. We need to ensure that we address the poverty that's in our communities. We need to ensure that people are at the center, and in terms of their participation, we need to bring all sectors into the decision making. And very, very importantly, we must be sincere that without this, we will not have development. And we need to get that to our policymakers and influence them. And I just want again that to reemphasize that COVAX should become a permanent mechanism. But more than that, that we need also to ensure that in the Latin America we develop and invest in our ability to produce for ourselves as well. So thank you very much. It's been a pleasure to be with you and to listen to all of you. And I look forward to meeting you again. And I want to know some more about the people's vaccine.
Well, thank you. We've had a great session. I just want to take a moment to thank Abby Maxman, César, Nuñez, and Carissa, Etienne. The three of you were brilliant. The topic couldn't be more important to our times, but as you've all said, equity is at the heart of everything we do, not just for COVID, but for all of global health, for now and for the future. So thank you, and we wish that the world will come together in solidarity for equity, health, and justice for all. Take care, everyone.
Thank you.
Bye.
Thanks so much.
Thanks.